to reducing structural approaches to reducing racial inequities in HIV. And then I'll mention our other March event on March 21st. It's a different special event from the Equity Core, the Health Equity Core of the HIV Center. And it'll be both a presentation and workshop led by Justin Knox, Jennifer Moots, and Amy Campbell from our HIV Center. And this is a presentation and workshop focused on a hybrid observational implementation science workshop. So that's going to be a very special event, March 21st. Please mark both in your calendar, March 7th, Natalie Crawford, March 21st, this workshop from our Equity Core. So without further ado, I will, unless anyone interrupts me for another different kind of announcement. No, I guess not. I want to introduce our speaker for today, and just very pleased to have a good colleague, and I think I can start to call friend, Dr. Sannisha Dale, who is an associate professor with tenure in psychology and a secondary appointment in public health sciences at the University of Miami. She's also a licensed clinical psychologist, yay, and the founder and director of the SHINE research program. SHINE stands for Strengthening Health Through Innovation and Engagement, and you'll hear about that today in the presentation. Her primary research interests are enhancing our understanding of the relationships between resilience, trauma, and health outcomes among individuals with HIV and those at risk for acquiring HIV, investigating psychosocial and structural factors that relate to HIV health inequities. All of this very dear to the new cores of our current HIV center. Also developing effective prevention, intervention, implementation strategies to promote resilience and good health outcomes among survivors of trauma and individuals with or placed at risk for HIV, especially individuals minoritized due to interlocking systems of oppression and who are heavily burdened by the HIV epidemic. And finally, across all of this, she's highly focused on engaging community members and stakeholders in research. Dr. Dale has been a PI of over 14 grants in the area of treatment and prevention. I'll just mention examples, including, for example, an R01, NIMH R01 focused on a bundled implementation strategy for HIV prevention in Black communities hardest hit by HIV in Miami. And at T32, dear to our hearts, our T32 fellows are here today, focused on training the next generation of scholars addressing HIV inequities. In addition to all of this research, she's director of the Mental Health Disparities and Community Engagement Core for our sister center, P30 in Miami, called Research in Mental Health, HIV Research Mental Health, known as CHARM, which is a great acronym for their center. And as you will hear today, Dr. Dale values community engagement and views strong community partners as the bedrock to conducting impactful HIV health equity research. And these efforts in engaging community members have been recognized by two very prestigious awards from the Rhoda Johnson Tuckett Award for Commitment to Community Engaged Research and the Community Hero Award. And lots of certificates and plaques of appreciation from community partners, including the Florida Department of Health. So thank you for being a hero. I can go on and on with her presentations and publications, but I won't because I want to turn the floor over to Sannisha. And thank you so much for joining us today. And the floor is yours.
Thank you for having me, everyone. And thank you so much again, Bob. This was a delight to say yes. And as I speak, feel free to put questions in the Q&A and also hold them until the end if you desire. But thank you for being here. Okay. Can everyone see that? If anyone can raise their hand or say yes.
Yes, looks good. Perfect.
All right. And so I think a lot of this was already spoken about, so I'll just say hi again. And I do a lot, but in ways that I appreciate and love. And throughout this talk, I'll be talking, a bit about my why in this work, because I feel like it's something that comes up for me every day. And it's what, keeps me here and keeps me doing this work. and how that has informed my work in HIV mental health and health equity. Disclosures, before I begin, I serve as a site PI and co-investigator on a Merck and company-funded project. It's a qualitative study exploring biomedical HIV prevention preferences among diverse women who are placed at risk for HIV in the US. And also, I've served as a consultant for a work group with Gilead Sciences for better engaging people living with HIV. So this is just a glimpse of my presentation overview. So why? And then I'll be talking a bit about my values and approach to research. I'll provide an overview of 4 projects. I don't have the time to go through all the work that we're doing, but I will provide an overview of 4 that will give you sort of a good sense of how we anchor things and what we're doing. I'll also talk about paying it forward because I think this, again, is aligned with my why and how we ought to be thinking about this work. And lastly, I'll talk about my leadership roles in terms of elevating community voices, even beyond my own research program. So why do I do this work? For me, it's about trying to make things better. And when I say better, meaning for my community, for the communities I'm a part of, for the communities that are being impacted by health inequities. And some might say, well, research is just research, and we get to the science. Why do we need to be philosophical and reflect on why we do this work? I will say that in the moments where academia felt heavy, in the moments when the paper writing, the grant writing, the everyday pragmatics of doing the work are challenging and hard, it's my why that keeps me coming back. I've often said to people when people have queried about, "Ooh, so would you be interested in this or this opportunity?" And I'll be frank, I know that I'll always be doing this work of contributing to the empowerment and upliftment of the Black community, of people who are impacted by health inequities. But to me, it's not a matter of where I do this work or with whom I do this work. My why is what is going to drive this journey. I'll do this work until the end, right? Or until the end of, say we get to the point where HIV is thoroughly addressed and people living with HIV truly have access to all, both the necessities and the resources to flourish, and oppression is a thing of the past. Whew, won't that be a day? I would still be in the work, be it from a mental health angle or from another angle of trying to empower communities. And so my why about why I show up every day, I want to be a part of the difference. I want to help and empower. I want to elevate voices and pass the mic. I want to do something that I would be proud of if I was to look back on my life's journey. And so that's what keeps me doing this work. And I think a lot of that has been informed by my own journey, be it as a young child. I was born in Jamaica before I my family immigrated to the US around like age 9. So that immigration experience, but also the experience of what it means to grow up in the context of low socioeconomic status and environment, but also the context of seeing isms and how they play out, be it in terms of race, be it in terms of homophobia, be it in terms of stigma, seeing those things all throughout my journey, and also simultaneously not only seeing those isms, but seeing resistance, seeing joy, seeing just the power and beauty within all our communities is something that has landed me on this why. So I'll continue to do that. And I hope that in talking about the projects, you'll get a sense of how that shows up. But this is really what gets me going and why I'm going to keep doing it. So again, the name of my research program is SHINE. And a lot of the work we do is around mental health and HIV and health, addressing health inequities. And we do this both in terms of thinking about psychosocial and structural factors, but also in terms of intervention and prevention work and community partnership. And there are a lot of us at any given time. It's approximately a team of 30. And this is an image that by now I think at least 30% are onto their next stages. So you're seeing both here core team members, full-time staff, but also graduate students, undergraduates, postdocs, et cetera. So I love to start off talks by kind of grounding us in where we are, because oftentimes in talking about mental health inequities and HIV inequities and disparities, a lot of questions will come up really early about behavioral behaviors and what behaviors are behind certain numbers or et cetera. And I think it's therefore important for us to start off saying that the literature has long proven that it's not just an individual behavior that is driving why we see the inequities and see disproportionate impact on many communities. It is largely structural factors. It's largely intersectional oppression. And that is manifested in many ways, be it through things we see around transportation, healthcare deserts, mass incarceration, racism, heterosexism, poverty, all of it, transphobia, food insecurity, all of the above. And so I like to ground us in terms of thinking about their systems at play. And so when we do this work, we have to be conscious of what those systems are as we do the work. I think many in the room, by the nature of being involved with the center that you're at or your roles, perhaps this data is sort of like speaking to the choir, but nonetheless, I'll just touch on it briefly. You know, these are some of the disparities that we see when we're looking in both in terms of people living with HIV, and then when we're looking at prevention, such as like PrEP uptake. And as you could see, again, taking the Black community as an example, there are large disparities, right? So Black males being impacted more, Black females, but also when you think about intersectionality, Black same gender loving men are more disproportionately impacted. When you think about intersectionality, again, for instance, thinking about Black trans women, right, who 50% of whom are impacted by HIV. So again, the need for an intersectional lens. When you look at prevention, again, PrEP, despite what we see in the disparities of who's most being impacted by HIV, we are not seeing the same reach in terms of PrEP, for those communities. An overview of mental health. Again, I may be preaching to the choir, but let's touch on it a little bit. There are higher rates of mental health struggles among people living with HIV in studies that have compared people living with HIV and people not living with HIV. And a lot of that, again, goes back to the slide I showed when we think about intersectional oppression. There are so many stressors, stigma, a major one, but all the other pieces that were noted there that exacerbate and can trigger mental health symptoms and struggles, right? And so we're seeing, about 42% of people living with HIV have struggled with depression compared to about 7% of people living without. And then when we look at trauma and PTSD symptoms, we're also seeing that as well. So I think a classic study by Matchinger and colleagues found that 30% of women living with HIV had recent PTSD, which is over 5 times the rate of PTSD in a national sample of women. Another thing to note is just even the modal number of criterion A trauma that people living with HIV may be exposed to. I recall reading literature indicating that it's about 5. And in the work that we do day to day in Shine, that's definitely echoed. Unfortunately, trauma exposure, violence exposure is more of a norm than it is an exception, which again speaks to the events that may exacerbate and lead to ongoing mental health struggles. I'd like to take a minute to talk about values and approach to research, given everything that I just noted. So a big part of understanding, yes, why am I doing this work? But then if I'm doing this work to empower, to center, to make a difference, then how are you doing this work also becomes important. And so the values that you take to the work and how they play out is also significant. One of the earliest lessons that were taught to me by a community matriarch, she's now an angel, um, is showing up and being present. So I remember my younger days in Boston saying her name is Irvine. And, I said, Irvine, I want to do this work right. And I want to do it well. And she said, Sannisha, just keep showing up. Like, that is it. You're showing up, keep showing up. And what she meant by that was not just, yes, you're going to the events and people are seeing you and et cetera, but show up to be of benefit to what's occurring. So don't just show up because I have a research idea and therefore I want to connect and therefore then I'm going to benefit by X. Show up when you don't see a research question aligned to it. Show up when you have an asset or something that can contribute to the event. So I would often be asked by community partners to, hey, we're having this event and we're wondering if you could come and take like 5 to 10 minutes of our agenda and talk about mental health treatment approaches or resources that people could utilize if they're just starting to think about accessing mental health tools, questions they may want to ask their provider, or when they show up at their first session and they're anxious about thinking about their journey, what would you suggest, right? And I would go. It wasn't a mapped out PowerPoint talk that would be taking half an hour, but I would just show up and be of benefit there, but also showing up in terms of seeing what's occurring. So many times I would show up to an event, the organizer and different people are moving around and I would say, do you need help with anything? Okay, sometimes it was sharing food. Sometimes it was helping to set up chairs. Sometimes it was greeting people at the door, but showing up and being present in that, like, I'm here as a full person and not just thinking of myself as Sannisha, Dr. Sannisha Dale, playing X, Y, and Z role, but how are you a part of community when you show up to these places, right? And so that has been a big part of how I do the work. My team, we show up, we're present, we engage, we support, and try to think about the goals of other community partners and the work that they're doing beyond us. Naturally, I think that what that lends itself to, true to my angels advice and mentorship, is that leads to people seeing you as someone who is authentically engaged and who want to be there, right? Not for a moment, again, not for a data point, but to be there. Another big part of how we do this work is center and research participants. So my team, we talk and they know our participants are assets. In the scope of thinking about research and learning and advancing the science, they are the assets. We learn nothing about human resilience, resistance, strategies, adversities, et cetera, without the human beings themselves. So treat them as such, right? We show appreciation. Thank yous are oftentimes we'll say that we'll get into a thank you train sometimes when we're doing things or engaging people where we'll say, thank you for so much for doing this. And then the other person will say, well, no, thank you. I appreciate X, Y, and Z. And so showing appreciation verbally, but it's also the subtlety of how you show appreciation to folks in terms of being understanding of what's happening for them. Adjusting the schedule if it needs to be adjusted, being flexible, and just the subtleties of your behaviors. I'll give one instance, and that has always stuck with me. I remember being in a session for an intervention with a participant, and we were sitting there, and she was drinking coffee that we had given her, and the lid fell off, and it kind of tipped. And she went forward to grab it, but I'd already tipped forward, and I was like, no, I got it. And I took it up and I cleaned it, and I bent down and was like cleaning the thing up. And she's like, you sure? And I was like, no, it's okay. Just take a second. This would be great. And I, got up, did what I needed to do. And I was like, what, flavor were you drinking? I'll go and grab you another one. And I did that and I come back. And she said to me, this is not just a job for you, is it? you actually want to do this. You actually want to help. And I say that story to say that it's the subtlety in how we are with people that can also communicate appreciation and value, and not just what you say explicitly. Minimizing barriers is also a part of that. And so thinking about, if you're recruiting participants or wanting to engage with individuals, think about what barriers they may face in terms of getting to you, right? Transportation, is that an issue? And if so, how do you offset that? If your schedule and how your team works is a barrier, then how are you flexible and work around that? For instance, one policy we have in Shine is if someone shows up for a visit on a date that's not actually scheduled, we make it work. Are there logistical pieces where it's like, okay, that wasn't the plan, but we're going to revamp that plan for today, right? And that has been very meaningful in minimizing barriers for participants who may have lost their phones, participants who may have experienced unstable housing. And so as a result, they had no way of communicating with us or remembering when the appointment was, but they'll show up because they know if you show up, we're going to see you. If you show up, we're going to engage with you. So minimizing barriers. The other part that's connected to that is attending to needs. The other thing our participants know is that they come to Shine, but Shine is a research program. It feels more than that to our participants, and we've been told that over and over. So if they show up and they say X, Y, and Z is happening, our team knows that someone has to attend to them, sitting down, figuring out what's happening. We have a community resource list that we're constantly updating with common resources that may be helpful to our participants. And a lot of these resources come from community partners, but also participants have told us resources. So someone shows up and says, such and such is happening, and I'm having an issue with this thing, we'll look through it and say, okay, what resources do we have that could connect someone to legal resources? Or what resources do we have in regards to shelter or housing? Or what resources do we have in regards to mental health, additional mental health services, right? So we attend to individuals' needs. Do we have all the resources? No, we don't. But we know that we could at least start. The other thing we do is that beyond that list, the team knows to escalate it. So if a participant sharing issues and things that are going on that are not as easily addressed by that, they escalate it, Dr. Dale, we need to consult with you about X, Y, and Z. And beyond Shine, we then reach out to our community partners in terms of asking, hey, we have such and such coming up. Do you know anything in community that might be helpful? What would you suggest? So attending to people's needs. And what that leads to is that because individuals feel held or seen in the context of that, they continue to come back to engage in the research, in the work, because it's seen as something bigger. I can't tell you the amount of times I've been stopped like outside at a community event or somewhere else, and someone will be like, "You're Dr. Dale." And I'm like, "Yeah, I'm Dr. Dale." And they're like, "I just want to tell you about your team," and usually it's like a 4 or 5 minute conversation about the way they have felt supported during things that have happened that, again, has nothing to do with the research, but the way our team interfaced with them throughout those issues and saw them as human beings has been something they appreciated. To the same breath, advocating, having letters behind your name, there's privilege to that. There are ways in which people will listen to you in ways that they're not listening to other people. It is unfortunate that that's the case, but in recognizing that privilege, you could also use that privilege for advocacy. And I was told early in my career, I remember someone saying to me, Sannisha, have you ever thought about how your role as a psychologist may be distinct from one of, say, like a case manager or a social worker? And I know where they were going with it. I was like, okay, what kind of mess is this? But they were saying that it seems like when you are engaging folks around mental health and things come up, you may take your time and go an extra mile outside of that session to help to advocate or connect them to something. And I think it's fully within all of our roles. There is no excuse for saying I am embedded in work where I see needs And I'm not going to take 5 minutes, take 10 minutes to connect someone to find a resource and follow up with a client or give them. Yes, do we hand them off to a case manager or someone else whose role might be predominantly that for thorough follow-up? Yes, but it doesn't hurt to take a few minutes if you think that your participation will actually help to move that needle. If you think that you could do a warm handoff that will make the participant more trusting of the next person in their process. And so we do think about advocacy as something that we should do. So there have been times when we send emails, we've had participants showing up, for instance, and say, I've experienced this disruption in my insurance, and because of that, I'm actually without my meds and da-da-da, and I've tried to reach out to this person or my doctor, and no one's gotten back to me. And we ask, would you like us to call them with you now, or would you like us to send an email on your behalf? I don't think it takes much. And I think it goes again to show how you center research participants as human beings. Recognizing strength and resilience, again, in thinking about intersectionality and interlocking systems of oppression, I think there may be a tendency to only see the isms. But in doing so, you strip communities that have strived, survived, have fought to be here and continue to fight. You strip them of so much of their narrative, right? The fact that resilience and resistance is embedded in intersectionality. And so recognizing strength and resilience in every research project you do, in every initiative you have, is an important thing to do. Partner with community members, I think that goes without saying. I think it's a big part of how we do the research in Shine. And then when we do work in developing interventions, assessing, cultural relevance, honoring intersectionality, really zoning in on competency around your, not just the direct clinicians, but your team, your staff, their training, and how you continue to revisit that is important. And then context and environment matters, right? Understanding the weight of what people are experiencing, understanding the impact of their contextual situation, socioeconomic factors, and where they live and try to navigate life. So in this talk, I'm going to be speaking about selected projects, 4 of our projects in Shine, and I'll go over them each one by one, but these are the overall titles. So Step 80, Striving Towards Empowerment and Medication Adherence, it is a 10-session individual intervention for Black women living with HIV. And it combines several things. So it combines evidence-based strategies for trauma symptom reduction. So using CBT strategies. And I say using CBT strategies because one has to know what CBT strategies are, cognitive behavioral therapy strategies, but also in what way it could be beneficial, but also being mindful of how it could be harmful if used incorrectly. So evidence-based strategies for trauma symptom reduction, strategies for coping with racial discrimination, HIV-related discrimination and stigma, and gender-related stressors that women face. And I want to say that the strategies that we're talking about here were actually coming not just from the literature, but actually in qualitative work that was done. And I'll touch on that a bit more later. But the 10th session also includes exercises to plan and practice self-care consistently. So self-care was a hallmark and is a hallmark of the intervention work in terms of what do you do for self-care? What does that look like for you as an individual? And how do you strategically plan that and make that a consistent part of taking care of your well-being? And also problem-solving techniques for medication adherence. As I said before, a lot of this was embedded in qualitative work that was done before. So interviews were conducted with 30 Black women living with HIV and 15 community stakeholders who actually informed the development of Step 80. So they informed it down to the T of, the interviews to guide what should be included and what it should look like, but also then once it was drafted and developed, going back to community stakeholders and having them go through it to give additional feedback. We then did an open pilot trial among 5 women. So some people call this kind of like theater testing, but essentially 5 women went through the intervention, and we did exit interviews and got additional information about what to tweak and how to improve it. And then the pilot RCT was conducted with 70 women, 35 randomized to what we call enhanced treatment as usual, and 35 to step AD. The enhanced treatment as usual was not just treatment as usual because there was biweekly check-in with the participants, and everyone got a session of a one-session medication adherence protocol. And so it wasn't treatment as usual. The other thing I will say is also that I think by the nature of Shine and the ethics with which we approach participants, irrespective of what study they're in or what arm of a study they're in, also makes it that it's a bit, it's more removed from treatment as usual. But we think that the ethics of center and participants is important to doing this work, period. So these were some findings from the open pilot. You could see that things were going in the direction we want them to. Clearly, with an open pilot, you're kind of looking at things from an individual case level and seeing the blips, but also looking closer into what might be contributing to those things. And so it gave us insights and refinement. I will say one of the other things from a fellow perspective, and as you all think about your future work and how you're doing things, is thinking about how what you encounter and the lessons you learn from project to project and step by step may actually inform additional work that you do. So the blips, take for instance, the blips that you see with trauma symptoms over time, a lot of those peaks. I went back and was looking at, okay, what were we seeing with these blips? And these blips were reoccurring trauma that was happening for the women, or macro discrimination acts, or issues that were happening for the women. And so actually that informed one of the R1 you will hear me talk about a bit, magic. So also think about that piece, how your ideas are connected. I don't think it's necessary to almost feel like, because there's this grind in research culture that will happen at times. And I've heard mentees talk about it. And clearly I've also been very much aware of it, where it's like, especially if you're in soft money, okay, what's the next project? What's the next this? What's the next this? And I would highly discourage people from doing that in terms of see the meaning in what you're doing as you go to the next thing. And I think that if you slow down in doing that, you will realize that you don't run out of next things to do. The other thing about it is that if you stay close to community, you will hear the echoes, the whispers, the conversations to inform what's next. So also don't make it that your next is like a me idea that I need to generate. Generating ideas and doing projects that will not make some meaningful impact or resonate with what people are struggling with and what people need may still land to projects, but it's not necessarily meaningful. And again, it comes back to your why. So if your why is truly to make an improvement and make change, then your projects and the questions you ask should be grounded in what improvements are needed and what you're hearing from people of lived expertise. For the pilot RCT, what we saw with Step AD is that there were significant ART improvements in terms of ART adherence. And there was also a significant likelihood of being less, for women in Step AD, less likely being diagnosed with PTSD by the end. I want to say that this was also powerful because I think that in Step AD, we don't do like a full on, the entire intervention is focused on just the trauma. It's 2 sessions focused on trauma. However, how trauma is defined and the tools and strategies, it's not just something that one should think about as a criterion A trauma, right? So we actually conceptualized and talked about adversities in general. There are ways in which racism is traumatic. Homophobia is traumatic, right? Sexism is traumatic. So how does one, in talking about coping strategies and healing and et cetera, help women and participants to see the dynamics of how things spread across? So women continue to work on their trauma, not just in terms of criterion A1, but also in thinking about the other adversities. But that was really powerful and neat to see. What the next steps for this work, we are awaiting, we're awaiting an award for this to do the large scale pilot RCT. The other thing I will share about the work that we've done with STEP-AD, our baseline sample was a nice sample, even though we randomized 7 women, it was about 119. And so we did work that actually also looked at the variables at baseline to see how these variables are operating with each other. I'll take us down to the bottom as one of the key examples first. At the bottom, what you're seeing there is a result from a network analysis. And essentially what a network analysis is, you know, when we do correlations or logistic regressions, it's kind of like looking at the relationship between 2 variables. And a network analysis says, what if I put these variables in together and see how they're connected to each other? Like, are there variables that will come to the center and stand out as like, I'm here and I'm connected to all these other variables you see around here? Or there are certain variables that are more at the end where it's like, okay, I'm not as central to the big picture, but still important. Another thing a network allows you to see is the strength of those connections. So what is central, but also what is the strength of those connections. So what you're seeing in the network here is in the middle where it says HSNG, it's actually the variable for housing stability, right? And what you're seeing around it up here, ADH, that's medication adherence. What you're seeing to the bottom right, MGG, that's microaggression. So that's gendered racial microaggressions, and that's the frequency of it. A little bit below MGGA, that's gendered racial microaggressions and the appraisal of it, so how stressful. And to the left of HSNG, INC, that's income. And so essentially, and then you also see connections down at the bottom, DEPs for depression, PTSD is lower, LEC is a number of traumatic events. You also see viral load and some other variables there. What is key here you see is that the most central variable ended up being housing stability. So housing stability impacted adherence, income, and all these other things. And it was the way by which all the other things were coming in and feed into the network. So what something like this may suggest is, again, what many advocates say in the context of HIV is that housing is health, it's well-being. And so it's important to address housing stability from a policy level and an access level. Over here on the left, what you're seeing is an SEM model, which essentially we did work looking at how latent gendered racial microaggressions related to medication adherence and look to see if there were interactions between gendered racial microaggressions and religious coping that impacted that relationship, and also how gendered racial microaggression and racism related coping impacted that relationship. And they did impact that relationship in terms of medication adherence. So again, don't just think about the adversities that people experience, but what are the coping strategies and tools that may actually help us in buffering these pathways that we're seeing. On the right-hand side, that kind of also told a similar story. So we did a latent profile analysis and essentially looking at if you were to group based on adversities and also resilience factors like religious coping, social support, post-traumatic growth, and look at adversities in terms of trauma exposure and discrimination based on HIV, race, and gendered racial microaggressions based on being Black and women. When you group those things together, I'll just take the solid line to kind of give you an example. The solid line is for women that were high in resilience and high in adversity, right? So women high in adversity and high in resilience. See there. And what we found, so there were grouping in different groupings. So there were some women who were low in resilience, low in adversity. There were women who were low in resilience, high in adversity. There were women who were high in resilience and low in adversity. When we then map these profiles onto mental health symptoms such as depression and PTSD symptoms, what we found consistently were that the women who had less mental health symptomology were women who were high in resilience, low in adversity. Again, echoing the need for the sociostructural changes, meaning that resilience is important. However, we need to also work on the system piece. So I'll move now to talk a bit about MI Prep. And MI Prep is a very brief intervention, 2 sessions. And MI Prep stands for Motivational Interviewing to Increase Motivation for PrEP Uptake Among Black Women Placed at Risk for HIV. And the first aim of this was to develop the 2-session counseling intervention, and it combines psychoeducation on PrEP and also the psychoeducation on PrEP with motivational interviewing, and also the session 2 continued to touch on psychoeducation on PrEP, motivational interviewing, and provide light case management. Like, so folks from the first session that occurred 2 weeks before came back and said, I am motivated and interested in PrEP, but when I went to the PrEP connection services, the Department of Health, I ran into X or Z, or I told my doctor this, and then I ran into this. Then we would actually help to problem solve, brainstorm and problem solve ways in which they may be able to navigate those things to access what they need around PrEP. The second aim, we developed the intervention, and then we did an open pilot trial with 10 women to kind of assess the feasibility, again, do exit interviews, and then we conducted a pilot RCT. From the open pilot, we saw evidence of acceptability and feasibility and really high satisfaction. Also increases in terms of PrEP uptake. Again, it's an open pilot, increases in knowledge, motivation, and women reported decreases in PrEP barriers and medical mistrust. It's interesting because these weren't primary things we set out to look at, but nonetheless, I love to measure these psychosocial related elements that we know are there for our communities. And so it was interesting that perhaps in having those conversations and beginning to navigate the process, there was women perceived a decrease in their barriers to get in the PrEP, and also medical mistrust. The other thing I will say about MI PrEP is that how it's delivered, we're also very attentive to thinking about like cultural congruency, right? So one thing about talking about PrEP is that it's done in a sex positive way. So it's not done, old school. And it's not just old school, because I still run into folks who think that the way to help individuals think about sexual health and well-being is to talk about or just say statistics that you perceive may induce fear. Fear doesn't do anything, right? It makes people scared, but I think it's problematic in the context of trying to promote healthy sexual behaviors, because sex and sexual health, people often associate with pleasure, right? Intimacy, joy, etc. And so there's a mismatch there. So one thing we do in MI Prep is it actually starts off very, very sex positive, and we keep that tone throughout. What do you enjoy about sex? What would you like to keep, do more of, change, etc. But also PrEP as a tool that you could utilize in the context of thinking about your sexual health and your sexual well-being, right? So think about, again, sex positivity, and PrEP is something that people can utilize as a tool. The other part about it is that even in the minutia of how things were done, so some of the PrEP education was done by video clips, some of it was done through talking through information, but those pieces were making sure that they were congruent. So the videos were of, for instance, Black women physician or Black women who utilized PrEP, again, to keep the congruency there. One thing I will say about MI Prep, even though I didn't show it there because it's under review, is that we also saw really, really awesome findings for the pilot RCT in ways that we expect to see them. The next study I'll talk about is MAGIC, which stands for Monitoring Microaggression in Universities to Inform Interventions for Change Among Black Women Living with HIV. And the first aim for MAGIC is to assess whether microaggressions experienced by Black women negatively impact HIV viral suppression by ways of mental health symptoms and health behaviors. We also do something unique where longitudinally we collect data on microaggressions experienced by Black women via short daily text message that they get. And it's 1 month out of the 3-month period between their major assessment visits that they get texts asking within the past 24 hours whether they've experienced any microaggressions and what identity they believe that was targeting. We also asked about how it made them feel in terms of distress. And there's an ethical part that's actually tied to this. And the participants know that if their distress rating is high, they get a message saying that someone from the team will be in contact with them to check in, and we check in within 24 hours. But the message also indicates that should they need someone to reach out sooner than that, these are the resources they should tap into, et cetera. The second aim of this, speaking to what I spoke about with the blips in Step 80 earlier, is also to look at how reoccurring trauma and violence experienced by the women, both directly and vicariously, may negatively be impacting their viral suppression as mediated by mental health symptoms and health behaviors. The last aim, but not lastly, because it goes back to my earlier point about resilience, is important in every question you're asking and how you're doing this work from a strengths-based perspective. And so the third aim is to determine if resilience factors moderate the relationships between what we examine in aims 1 and 2. And so we're looking at resilience measured at the individual level, interpersonal level, but also at the neighborhood level. And so even though this is a longitudinal study and it's still going on, it won't be completed until 2025, the end of 2025. We have published a couple papers from the baseline data. And so one of them I'll present a bit about here is one looking at neighborhood characteristics and how it relates to intersectional discrimination, mental health, and HIV outcomes among the Black women living with HIV. And so this slide is showing relationships that we found. And one thing I will say about this approach to looking at these is we utilized some novel like spatial analysis that was utilized by Dr. Wright, my collaborator on this work, and spatial analysis allows you to look at how things are related in terms of within neighborhood factors. So how is it that the neighborhood that you live in terms of census tract or zip code, for instance, how is it that the factors linked to that neighborhood, be it things like, and you could look at anything from the census, available data that you have from the census or other different large data sets, but how is it that those factors within that area relates to your experiences and health outcomes? But also spatial allows you to look at how is it that neighboring areas are also impacting those variables. And so we found that within neighborhood factors were related to intersectional discrimination that the women were experiencing. And this is intersectional discrimination in terms of both microaggressions, both more macro discrimination acts, and across identities, including race, gender, living with HIV, sexual orientation, et cetera. And so we found that higher crime was associated with experiencing higher gendered racial microaggressions. Higher employment was a resilience factor that showed up, or a resource here, that higher employment within the neighborhoods that you live, a higher employment rate was actually associated with lower HIV microaggressions and lower HIV-related discrimination. And also that higher number of low income or subsidized housing rental units, again, from an access point of view, housing being a major issue, was associated with lower HIV microaggressions. And on the flip side, higher neighborhood median income was associated with higher HIV microaggressions and higher sexual orientation related discrimination. One thing to note about this as you're thinking about what do these findings mean, I think anyone would agree that employment makes a difference, right? But also housing and access to that and who's around will make a difference. But the other thing to think about is what is the individual's own status around these things in terms of employment and income and the overall neighborhood thing. Because perhaps if there's an incongruency or a disparity between I am of lower income, but I'm in a neighborhood that's of higher income, one could see where perceived status in terms of income and the individual might result in other people treating them less than and engaging in microaggressive acts, right? When we looked at the neighborhood areas in terms of how that related to these experiences, we saw that higher education in neighboring areas was associated with lower gender racial microaggression appraisal. So perhaps, again, if we are we live in X neighborhood, but the neighborhoods we're commuting across or going into for different things, people are of higher education. Hopefully, one would hope that people who are more highly educated would engage in less gender racial microaggressions. But at the same time, there's a flipped relationship where higher median income was associated with higher gender racial microaggression. Again, the disparity between where you are in income and where other people may be some of the sites. One thing I will say with looking at neighborhood factors, it's important to think about that you're not going to find relationships in one way, nor should you. There's a nuanced story to be told in how these factors may interrelate. And so paying attention to them and continuing to add to the science is important. Similarly, we looked at how these neighborhood characteristics related to mental health, and a lot of these are in ways that you may predict or literature would support. So higher crime associated with higher depressive symptoms and post-traumatic cognitions, higher crime related to higher likelihood of PTSD diagnosis and substance use disorder. But higher employment in your neighborhood was related to lower PTSD symptoms and lower likelihood of alcohol use disorder. Higher education in your neighborhood was associated with lower likelihood of suicidality, and a higher number of Christian organizations was associated with lower post-traumatic stress cognitions and lower likelihood of depression diagnosis. And again, when you think about church and faith and their role in the Black community, this may say something about that. However, we know that church faith is complex, and there are ways in which churches have been a source of harm for many minoritized groups. And then when you look at the neighbor and neighborhoods, again, you see some interest in sometimes contradictory relationships, but noteworthy and important to think about why that may be. So higher education in neighborhoods was associated with lower numbers of traumas, depressive symptoms, lower PTSD symptoms, et cetera. But higher employment in the neighboring neighborhood was the inverse relationship. The other thing you want to think about when you think about neighborhood context is it's where you live, but what's next to you, but also what is happening when we think about what's next to you, right? So sometimes when we think about where people live, gentrification may be something that's actively happening in terms of in the borders of their neighborhoods or what's occurring. And so with gentrification comes a lot of these changes in sort of like a lower income census tract being next to a higher income census tract and all these variables that are shifting. And it also shifts the demographics of who's next to you and therefore what might transpire in terms of your experiences. I'm going to keep us moving for the sake of time. When we looked at HIV health outcomes, we saw similar things. So higher crime related to lower medication adherence and also higher viral load. But again, here comes education and employment, that if you're in a neighborhood where the education is higher and when the employment rates are higher, it's relating to better HIV health outcomes, right? So overall implications from this work and paper is, again, it comes back to the policy level. We need to improve neighborhood education, employment, low-income housing from an access point of view, and also religious organizations with a caveat. Again, religious organizations that could truly serve the holistic needs of Black women living with HIV. And decrease crime, right? I think we could all agree on that's been a number one policy that's need to increase generationally. The other thing here to note is there also needs to be a focus not just on the neighborhood level, but on the household income of the participants to decrease the income disparities they are experiencing. One thing I didn't share here, but one thing that we know from these analyses as well, and that we looked at separately, is that for the women, when you looked at their individual household income, that was consistently related in the conceptual ways that we think it would. So women who had higher household income were doing better in terms of their mental health, their HIV outcomes, et cetera, right? But again, when we're looking at the environment, we're seeing that the environment level around income often had some contradictory messaging, which again could play on are there disparities between what the women have as a household level and then the income level of their neighborhood and what that might mean for their experiences. The other, we had another paper here, and I'll just touch on this one, is we did a paper doing SEM, and we looked at how these intersectional microaggressions and discrimination related to resilience. And this was, again, resilience using several constructs. Again, you'll see that we don't just think about resilience as one thing, but resilience resources many things at the individual, interpersonal, and neighborhood level. So here we were looking at resilience in terms of individual measures around trait and coping, self-efficacy, but also spirituality, but also post-traumatic growth. And at the interpersonal level, we're looking at it in terms of social support. And what we found here is that latent microaggression significantly predicted higher mental health symptoms, and latent resilience predicted lower mental health symptoms. And latent discrimination, there were no initial significant relationships that you saw right here, but I'm going to show you some work from looking at some moderations in 1 second. But essentially, microaggression stood out more in this model than the more macro discrimination acts. And that's important to note as well. In microaggressions it doesn't mean that they have less of an impact. They may be subtle acts that are happening, but they have a macro and a big impact on people's mental health and well-being. So that's something to take away as well. The nature of them being everyday acts also make it that they likely have a big cumulative effect as well, right? So we did some moderation and analysis to look at how the interaction between latent resilience and latent discrimination and how that related to mental health, and also looking at the interaction between latent resilience and latent microaggression and how that related to PTSD, PTSD symptoms, I should say, not mental health overall, but PTSD symptoms. I think we looked at both of them, depression and the overall mental health as well. But the slide I have here is looking at the PTSD symptomology. And we did find significant moderation that occur. So if we take the red line, for instance, on the one tier further left, what we're showing here is that the red line are for low levels of latent resilience, right? And the blue line is for high level of latent resilience. And so if you take the high level of latent resilience, and then you look at the bottom in terms of the latent discrimination that were occurring, when the latent discrimination is increasing, you're actually seeing a lowering of the post-traumatic stress disorder symptoms that are being reported. So, in other words, for people who were high in resilience, there was a buffering effect that was happening here where you're not seeing them report higher symptoms of PTSD even when the latent discrimination is increasing. So suppose there's some resilience in terms of both their social support, individual resources, etc. But however, conversely, for the individuals who were scoring lower on level of latent resilience, as the discrimination increased, there was an increase in their PTSD symptomology. And again, a similar pattern when we looked at the interaction between latent resilience and latent microaggression. So again, resilience is important, but again, thinking about resilience, not just at the individual level, but also at the interpersonal level is important. And back to the other paper, the neighborhood level is important. And again, the call on the need for policy. I'm going to keep going and wrap us up real quick so that we can have our Q&A. So the other project I want to talk a bit about that I'm super excited about, it's been so many years in the making in terms of all the groundwork for this, is our 5-point initiative. And it was initially funded as an original EHE supplement, so a 1-year supplement. And then it was funded as a 2-year implementation EHE supplement again. And you see all the logos at the bottom. Those are logos from many of our partners who have partnered with us in doing this work for the 5-point initiative. And I'll give you a breakdown of exactly what that is in 1 second. So if you look to the right, you'll see an image here. Essentially what the 5-point initiative is it's an approach that we use. So it's a bundled kind of strategy approach because it has many pieces, but how we do it is a big part of what's making the movement. So this is done within high impact, HIV high impact neighborhoods in Miami. And we partner with venues that are frequented by Black customers. And so we partner with laundromats, corner stores, car service providers, and also hair and beauty supply and barbershop. And the key voices in terms of doing this work, we are the community businesses, community health partners that help us to do this work, community residents, and community consultants who are people of lived expertise. Now, you might say, what exactly is this? The beauty of the 5-point initiative is that to community residents, it just looks like an outreach. Like people are coming out to do something in the community. And so we coordinate outreach events with local venues. So the businesses are already our local partners. So we go out, we set up, and we then administer a survey. And for residents, they complete the survey, which help us to get some of the research data. But then they also engage in the health behavior, which is HIV testing, and then screening and referral for PrEP as indicated, right? And in doing this, the beauty of the model is that everyone benefits, and that's important from an equity point of view. So the residents get a cash voucher, and a cash voucher that they spend in the business, right? So for past years, it's been $20. We've increased it to $25, but they get a cash voucher for engaging with the survey and the health behavior, and then they spend it directly in the businesses. So the businesses increase their daily revenue. For the community health partners who actually come into the model and provide the HIV testing, PrEP screening, and PrEP referral as needed and follow-up, they get to increase their reach because most of these community health partners are already paid to do this kind of work, but they're not necessarily reaching the individuals who need to be reached most. And then in terms of another important part of the model is community consultants. They're hired, they're paid as such, they're from these communities, they know the communities, and they're an important part of bridging the relationship between us and the businesses and the residents. We're also very attentive to ensuring that our team itself, in terms of the employees within Shine, are representative of the community and has excellent lived expertise. In doing this work over the years, we've collaborated with over 80 local businesses, 8 community health partners. For the first 2 supplements, we had 6 community consultants and experts, and you'll see some of their images on the side. Together, they bring a wealth of information, again, about the local community. And a lot of the different engagement strategies that we use, there's debriefing following following events, their weekly team meetings, exit interviews, resident feedback, and a lot of bidirectional communication as well. And I want to stop for a second to play this because I think it resonates again with thinking about our own whys. But this is a clip we took of some of our community consultants during the first 2 supplements. Okay, can everyone hear that?
My why is me.
No?
I represent my community.
I do this is because Miami-Dade County is very high for HIV/AIDS as well as the
Why is that I represent the community that I serve. I'm a Black woman living in Miami, which is the epicenter, to do awareness, prevention, and ending stigma. That's my why, because we need to know, get tested, know your status. It's better to know than not know. There is life after diagnosis. Live it.
Hopefully you were all able to hear that. If not, I'll try it towards the end.
Yes, no, we could hear it.
You could hear it. Okay, thank you. And you see that as well because one thing to know when we think about HIV, it's to think about the social structural factors and the numbers, and then think about in the context of COVID. These are the same neighborhoods who are disproportionately impacted. So when our team has been out from 2020, doing all of this work, we were very conscious of how we do this work in terms of both education and access. And we actually swapped out and offered different health behaviors using this model. So offered COVID testing and COVID vaccine utilizing the model as well. Okay, I'm gonna stop us after this. And it's been great work, so I'll tell you about the next step. We are doing a bundled, we're doing a cluster randomized trial of this strategy now, where we're doing it in 8 neighborhoods using a step wedge design. And we're gonna be in each neighborhood for over 21 months and doing at least 2 coordinated events each month in each zip code. And this is going to be going on for several years because it's supported by an R1, and we're hoping to reach over 20,000 individuals. I'm going to stop right here because I want the Q&A, but mentorship is big for us in Shine. We do a lot of mentorship and paying it forward. But let me stop there.